Hello, my name is Marika Saar, and my presentation will be about interactions with the medicine used in the treatment of breast cancer. Starting with the definition, a drug interaction is a reaction between one or more drugs, or it could be also reaction between a drug and food or between a drug and supplement. And as a consequence, drug interactions can potentiate or reduce a medication's effect and to lead to unwanted outcomes. And from the studies, we know that up to 1/3 of adverse drug reactions may result from drug interactions. So it's a big problem. And as we're talking about the breast cancer patients, we know that they may use lots of medications, including anti-cancer drugs, hormonal agents, and also supportive medicines. So they are more vulnerable to potential drug interactions. And what about the prevalence? How common the problem is? Studies conducted in ambulatory cancer patients, not only with breast cancer, but also with other type of cancers, they have reported that even up to 60% of all patients could have at least one drug-drug interactions. And a recent study among breast cancer patients identified that most of the patients had drug-drug interactions. However, not all of those were major interactions. Those were reported in 62 patients. And also what is known that most common interactions were between cancer drugs and supportive care drugs. And moreover, also studies have shown that 4% of mortality among cancer patients was because of the drug interaction. Again, pointing that's the problem which should be taken into account. Not all patients may have risk for drug interaction. There are certain risk factors which could lead to the drug interactions, including patient-specific factors such as age, gender, also genetic variations, and people with concomitant diseases, and therefore taking many drugs or several medications are in bigger risk of getting drug interactions. There are also drug-related factors, such as drugs with narrow therapeutic window and drugs which are strong CYP enzyme inhibitor and inducers. We will talk more about in following slides. Drug interactions can be classified into two groups. Either pharmacokinetic drug interactions, meaning that different pharmacokinetic properties like absorption, distribution, metabolism, or excretion of a certain drug could be altered by another drug. Or the second group of drug-drug interaction, pharmacodynamic interactions, mean that when two drugs are used at the same time, they may have either additive, synergistic, or antagonistic effect. And as most of the problematic drug-drug interactions are pharmacokinetic type of interaction, so therefore one slide explaining what is behind that. Most common pharmacokinetic interaction, they could occur at the drug metabolism level. So many drugs, up to 70–80%, are metabolized by cytochrome P450 enzyme, so-called CYP enzyme, and those are expressed mainly in the liver. And there are competition which happens between the enzyme. So most of the enzymes are substrates. So it means that the drug which is metabolized by one or another CYP enzyme, and the other drug which could be either inhibitor of this certain enzyme or inducer of the certain enzyme, may either, in case of inhibiting the drug metabolism, it may lead to increased risk of toxicity, or if another drug induces the drug metabolism, it may lead to increased risk of drug failure, because the metabolism is happening more faster or quicker. On this slide, let me give you some examples of drug with the most important cytochrome enzymes, including both inhibitors and inducers. And as you see that some of the antibiotics could be inhibitors like quinolone type, ciprofloxacin, levofloxacin, etc. Also macrolides like clarithromycin could be a strong inhibitor. Also some antidepressants, also PPIs, and some antifungal agents as well. And there are also some strong inducers which may decrease the effect of another drug. You can see here some drugs like rifampicin, carbamazepine, omeprazole, but also tobacco smoke may induce the metabolism of some drugs and lead to a decreased effect of this another drug. Not all drug-drug interactions are clinically relevant, so that's why we need also to understand what is the, from one hand, severity of the interactions. Is it major? So it means that in that case, the effect of interaction may result in hospitalization or permanent injury, therapeutic failure, or even death, or the effect may be minor. So in most cases, it doesn't need any medical intervention at all. And on the other hand, which is also important to know, what is the reliability rating of the interaction? Is it excellent? It means that there are quite a lot of data about these interactions. There could be multiple randomized clinical trials or single randomized trial plus more than 2 case report. Or on the other hand, the rating could be poor, fair, or even poor, meaning that there are just only a couple of case reports and no other supporting data. Going further, what kind of clinical resources do we have for drug interaction? Where can we get the information about the interactions in clinical practice? So first, and maybe the easiest way to find it about the product information, which is available from the manufacturer of certain drugs. It can be either package information leaflet, which is in the package, patient information leaflet, sorry, which is in every package. Or it could be summary of product characteristics, which is meant for healthcare professional, which includes more information, and it is available on the competent authorities website, either EMA website or national website of competent authorities. There are also several databases where information about interactions could be found. Some of them are listed here, together with links. But there are some questions or some issues which should be taken into account as well while checking the information about interactions. First of all, is this information always available? I mean, some of the databases are free of charge, some are not, so it may be not easy to find the good database. It may not be available for everyone. Reliability, meaning that you should also know how often is the database up to date, how often the new information will be added, and how relevant the information is. Next question, is it applicable in daily practice? Is the information enough for you to make decision? Is it just describing the interaction, or does it also provide some information what to do in case of interaction happens? Should I stop another drug? Should I modify the dose, etc.? And also the next question here is for which group this information is meant. Is it meant for patient, or is it meant for a healthcare professional? And can we find more information behind the just description of interaction? Is there any clinical trials or clinical reports, case reports reported there, and explanation of the drug interaction and recommendation or not? And here you can see one example taken from Lexicon Drug Interaction database, and it describes here a risk rating. In this database you can find it like in 5 categories. The strongest is with X. It means you should avoid this combination. Or D, which means you should consider therapy modification. With C, you should monitor therapy. Those three, X, D, and C, are clinically relevant interactions, and there are also B, which means no action needed, and A, which means there is not known interaction at all. And in that database, and also in others, there is summary of this interaction, there is severity and reliability rating, and there is also a recommendation for patient management. It could be either you should stop the drug, one of the drugs, or you modify the dose, or there could be also information of potential alternative. For example, if the drugs is recommended to stop. And to make it easier for you to understand, I have put here some examples of real life cases. And let's check for the case number 1. Here we have a female patient, 48 years, with metastatic breast cancer, and she's getting treatment with oral palbociclib 125 milligrams once daily, plus intramuscular fulvestrant once monthly. And she is taking no other medicines. She came to the hospital describing episodes of severe shooting or jabbing pain that felt like an electric shock. And trigeminal neuralgia was diagnosed, and treatment with oral carbamazepine 200 milligrams twice daily was prescribed. And my question, could you identify any drug-drug interaction problem here? So not many drugs to check. Now you, when you are listening the lecture at home, then you can stop here, think about the problem, and try to solve it by yourself, and then move further to the next slide when we when we already have checked the interaction. And I used the Lexicon database again, and here we can see that there is a clinically relevant interaction present. And it is between palbociclib, which is the drug for breast cancer, which is metabolized with the CYP3A E enzyme, and carbamazepine, which is strong inducer of the same enzyme. And checking about this interaction, we can see that the risk rating is X. It means you should avoid this combination. And why? This is the summary about the drug interaction, describing that strong CYP3A4 inducers like carbamazepine may decrease the serum concentration of palbociclib. It means that while the concentration of this cancer drug is decreasing, it may not help anymore. It may not be effective. And severity is major. This is the major interaction, and with good data behind it. Reliability rating is good. And what should be done? What is the patient management here? You should avoid concurrent use of a strong CYP3A4 inducer with palbociclib. It means that we cannot stop the breast cancer drug here, but rather the doctor should find another agent for treating the trigeminal neuralgia. Let's go further. Case number 2. Same patient again. Palbociclib and fulvestrant, the treatment, but the problem is different. She went to the GP, general practitioner, due to the skin problems. She described it as an itchy, scaly rash between toes. And the doctor prescribed oral itraconazole. It's a fungal drug, 200 milligrams twice daily to treat Taenia pedis infection. Again, my question, could you identify any drug-drug interaction problem here? You may take a stop here, a pause here, and think about it, and then check the next slide. And here we can see again clinically relevant drug-drug interaction, but this time it's also between palbociclib, and now with this enzyme is same, but now we can see another drug which is itraconazole and which is CYP3A4 inhibitor. It means that the inhibitor reduces the clearance of drug, this palbociclib. It increases the blood levels or concentration, and it may also increase the side effects because the concentration is higher. And when we're checking this Lexicomp database, we can see that risk rating is D, clinically relevant, meaning you should consider therapy modification. Summary, as I said, it is the strong CYP3A4 inhibitor. Serum concentration maybe of palbociclib may be increased. Severity is major, and data behind it, reliability rating is good. And what about the patient management? Here, if possible, better is to avoid concurrent use. But if sometimes it's not the case, we only have bad choices, we cannot replace the drug. So here it is possible, if the use of strong CYP3A4 inhibitor, in that case itraconazole, is not possible, cannot be avoided, then you should decrease the palbociclib dose to 75 milligrams daily. And when another important point, when the treatment with the itraconazole is finished, it means following discontinuation of the itraconazole, then you should consider an increase to the pre-interaction palbociclib dose, again, not to fail in cancer therapy. So you can see we had one example with inducer and another with inhibitors. The next case. Here we have a 58 years female, and she was started the therapy with olaparib tablets, 300 milligrams twice daily. And because of BRCA1/2 mutated HER2 negative metastatic breast cancer. And the patient asks for your advice about administering her new drug. And the question for you, is there any food or drink she should avoid? And the second question, Should tablets be taken with or without food? And why I ask this question? It's because could also be not only the drug-drug interaction, but also drug-food interaction. So here you can, one example, the grapefruit juice. And we can see that the grapefruit juice together with olaparib is not good combination, and according to the lexicon drug interaction database, it should be avoided. And why? It's because furanocoumarins, which are one of the components in grapefruit juice, they may increase the serum concentration of olaparib and therefore lead to increased toxicity. And here we can see the severity is not that high, it's moderate, but the reliability rating is good. It's quite a lot of data behind it. And the patient management or recommendation is you should avoid regular consumption of grapefruit and also grapefruit juice during treatment with olaparib. And it was another question about taking the drug with food. The recommendation here is it could be taken without regard to meals, either with or without food. But in some drugs, it may be important. And a little bit more about this grapefruit interaction. It does not concern only grapefruit, but also similar fruits, such as Seville oranges, those red oranges, also pomelos and limes, and those all contain furanocoumarins, which inhibit the enzyme CYP3A4 and therefore cause interactions and may lead to side effects of the drug they are taking together. And I put here some examples of drugs which are used in the treatment of breast cancer. So everolimus, lapatinib, olaparib, palbociclib, they shouldn't be taken together with grapefruit juice, or grapefruit juice shouldn't be used during the treatment with these drugs. And also neratinib, and in the information given by drug manufacturer, it is stated that with neratinib, either grapefruit or pomegranate juice shouldn't be consumed. And another thing with drug-food interaction, which should be taken into account, is when to take the oral medication. Is it important to take it with food or on empty stomach? Sometimes it really affects the outcome of the treatment. For example, capecitabine. Here I put some examples of drugs which are used in breast cancer treatment. Capecitabine, it should be taken with food and preferably after meal because it helps to absorb the drug on the other hand, and also it helps to decrease the adverse effects. For example, with lapatinib, it should be taken on empty stomach, not with food, because food increases the bioavailability of the drug, and that's why may increase the risk of side effects. Or palbociclib, which should be taken with food to make the drug to work or to be effective, because if the palbociclib is taken on empty stomach, then it may absorb not so good, not so well, and to ensure the effectiveness of drug, it should be taken always with food. But sometimes the food interactions can be difficult to manage, because the patient may have changed to his or her, mostly, if you talk about the breast cancer patient, lifestyle, and it may also lower the adherence. But it's our role to explain the patient, for example, why you shouldn't drink grapefruit juice, or why you should take a drug with empty stomach, on empty stomach, or with food. Then we help patients also understand the reason behind that, and also improve the adherence. The next case. Here we have 51-year female with locally advanced HER2 positive breast cancer, and she is on treatment with docetaxel and trastuzumab pertuzumab. And now patients comes to the next treatment cycle and asks for your advice about dietary supplements. She was advised by her relative to take supplement containing vitamins A, C, coenzyme Q10, and magnesium, calcium, and zinc. So now, what is your opinion? Would you recommend to take this supplement? You can take a break and think about it, and then go further with the next slide. So we know that the use of dietary supplements after a cancer diagnosis is quite common. But the thing is, or we should know, that antioxidants could reduce efficacy of chemotherapy and also radiation therapy. And why? It's because one cytotoxic mechanism of cancer therapeutics is through the generation of reactive oxygen species. So I put you two examples here on the boxes. There are two studies, both made with breast cancer patients. And in these studies, the patient used different antioxidant supplements. And in the studies, it has shown, or results showed, that there is an increased risk of total mortality and worsened recurrence-free survival in case patient in that group where patient used antioxidant dietary supplement during their chemotherapy or radiation therapy. And also the second study, it has been shown that that use of antioxidant supplements before and during treatment, it was associated with an increased hazard or recurrence of disease and also death. So Therefore, the conclusion here is that the use of supplemental antioxidants during chemotherapy and also radiation therapy should be discouraged. So that's our role to inform patients, rather not to use it during the therapy. Next case, number 5. Here we have 65 years female with hormone receptor positive, HER2 positive metastatic breast cancer. And she's on treatment with oral lapatinib, 1,500 milligram once daily in combination with letrozole, 2.5 mils once daily. And she has also hypertension. She's taking amlodipine for the hypertension, and she also has diabetes, and she's taking metformin tablets to treat her diabetes. After your question about any complaints or problems, the patient admits that she has been feeling depressed and has had sleeping problems in last 2 weeks. She's afraid to take any other medicines and therefore has bought 2 days ago herbal product which should be safe and without any side effects according to the information on the product label. You ask to see the product and you realize that it contains valerian, it's a herb, and another herb, St. John's wort. Now, what is your opinion? Is the herbal product safe for the patient? Could you identify any drug-herb interaction problem? Now we move on with next interaction type, drug-herb. You can think about it. We move further, and after you have looked for some information, you can also move further. So first, some background. Drug-herb interaction is, or use of herbal products is also quite common about cancer patients. There are several studies about the use of herbal products, and one example here. It has been reported that up to 80% of patients they use some kind of supplement, herbal supplement while on chemotherapy. And in this study, the authors they found out that about 1/3 of patients could be at risk of potential herb-drug interaction. So it's quite a high number. And on another issue here is that cancer patients often believe that herbal supplements could support their health. They are not toxic, they do not have any side effects, and they also the patients also do not think that could make any harm or have any interactions. But the truth is that there could be potential herb-drug interactions, also clinically relevant ones, and as a consequence, they may lead to either ineffectiveness of cancer drugs or increased risk of toxicity. So, coming back to our patient, we can, and checking for example, the lexicon interaction database, as I did, we realize that there is a clinically relevant interaction between lapatinib and St. John's wort, and with a risk ranking, the highest risk with X, it means you should avoid this combination. And what is behind that? So St. John's wort is a strong inducer, and it may decrease the serum concentration of lapatinib, and as a consequence, it may decrease the effect of cancer drug, effect of lapatinib. As you see, the severity is major, and also the data behind it, reliability rating is good. And what is the recommendation? What should be done in case of this interaction? So the recommendation is that the use of this food supplement, including containing St. John's wort, should generally be avoided during treatment with lapatinib. And in case it couldn't be avoided, you should consider titrating lapatinib dose gradually from 1,500 milligrams a day up to 5,500 milligrams a day. And it depending a little bit about the indication why the lapatinib is used. That's our patient case, or the indication of our patient. And this dose increase should be based on patient's tolerability. But as you see, how much the dose should be increased, it just meaning that the interaction is really strong, major, and it's rather it's more safe to not to start the treatment with that herbal supplement at all. And some more information about the drug-herb interactions. So there are, at the moment, there are known some herbal products which may have a clinically relevant interaction with cancer drugs, such as garlic, ginger, already mentioned St. John's wort, milk thistle, valerian, golden root, and so on. Why I said up to now, or at the moment we know, it's because to brought the herbal products to the market, they do not need the producers or manufacturers, they do not have to perform clinical trials like if you launch the medicine. With medicine or with the drugs, you have to prove the safety and efficacy of the drug, but that's not the case with herbal products. It means we do not have often information about their safety or efficacy, and also about the potential interactions. But however, some information we have, and we know about these herbal products I already mentioned. There could be clinically relevant interaction, and also some other examples here, like echinacea and tamoxifen. If you use them together, it could be end up, or it could be the efficacy of tamoxifen could be reduced using aloe vera and palbociclib together. So it may lead to decreased absorption of cancer drug, and it also may cause digestive disorders. And the third example, curcumin, which is in one of the components in turmeric root. If you use them together with talazoparib, it may lead to increased exposure of talazoparib and can increase the risk of side effect of the drug. So to sum up, the influence of herbal substances on chemotherapeutics is often unknown, but it may be harmful and we should think about it. And in case of those herbal products, we know the information, like here the St. John's wort, we should inform the patient and recommend them rather to avoid them. And now we move on how to prevent the drug interaction, because the best way is always prevention. It could be done either on patient level, so starting with taking proper medical and drug history. So we should not only ask about the patient about concomitant medication, but also about herbal supplements, vitamins, and also lifestyle habits, because sometimes smoking or alcohol consumption may also affect the drugs or may have interaction. The second point is monitor the patient, and especially those which may have higher risk for drug-drug interaction. And the third point, if we talk about the patient level, is discussion with patients. So we should try to increase the adherence for breast cancer therapy, but also for other potential therapies. Because if the patient is not taking medicine correctly, it may increase the risk also for potential drug interactions. So, and as I explained you with when we had the patient case with a food drug interaction, if the patient understands the reason behind why she should take the drug with food or in empty stomach, then she is hopefully better adherent to the therapy as well. Other way to prevent the drug interactions is on organizational level. It means that development of medication databases and also electronic prescribing systems may help us as a healthcare professional properly detect the clinically relevant drug interactions. And also the second prevention way of prevention on organizational level is to enhance alertness and knowledge of healthcare professionals about clinically relevant drug interactions, so that all members of healthcare team, including doctors, medical students, nursing staff, and so on, are aware about this problem and can address them. And to conclude, We may say that the drug-drug interactions are of major concern in oncology, in the treatment also of breast cancer patients, since the cancer patient often take not only the drugs for breast cancer, but other medication. And most of the drug interactions which are found in breast cancer therapy, they may have adverse consequences on patient health and also therapeutic outcomes. Those interactions may either increase the risk of side effects causing toxicity, or on the other hand, they may lead to ineffectiveness of treatment, and therefore because of the inhibition of some drugs by subenzymes, for example. And clinical intervention on interactions are frequently required among patients starting with anti-cancer therapy. And last but not least, screening for potentially clinically relevant interactions by oncologists in close collaboration with nurses and also with pharmacists should always take place before the start and also during the anti-cancer treatment. Here I used references and my information, and I would like to thank you for your attention and good luck with your patients and with detecting and preventing the interactions. Thank you.